Welcome back, everyone, and welcome to our show. My name is Dede Reyes, and I'm the host for Dede Talks, the Art of Specialty Lenses. Today, we have a really special guest. Dr. Jason Jedlicka is with us today. Jason, tell us a little bit about yourself.
Well, hi, Dede. Thanks for allowing me to be part of this great program.
Super excited you're here.
Tell you about myself. Well, 5'6". Oh, you mean like what do I do and all that? So I am a professor, clinical professor at Indiana University School of Optometry. So I have the privilege of teaching the next generation of optometrists contact lenses. So if none of them know how to fit contacts, it's all my fault. I spend half my week or so in clinic, spend a little bit of time in the classroom with teaching, get to do a little bit of speaking and writing, just a whole wide variety of fun activities I get to do. And it's a good life.
Well, and you're good at it. I've seen you in action. So I just want to talk to you a little bit about some of the real world fitting tips that you can give to new practitioners. So let's talk a little bit about what your best tips are for integrating scleral lenses into practice. And I know you've been in private practice before, but also how do you teach your students to do that?
Sure. So I'm going to back up just a smidge because, fitting scleral lenses is kind of the same as fitting ortho-K. They're pretty much the same exact thing. And for most of us in our practices who want to fit specialty lenses, we probably have a whole lot more young myopes and presbyopes than we do irregular corneas. So if you're wanting to practice specialty contact lenses and you're thinking, where am I going to get these scleral lens patients from? My advice has always been is to start with the patients you have. And you've got ortho-K candidates. You got like hundreds of them. And you've got multifocal GP candidates, probably hundreds of them. And those people are in your practice now. And you can start building your skills with specialty contact lenses with the patients you already have. And then as those patients who do need sclerals show up and you fit them and you've got the skill level in specialty lenses, you'll grow a reputation. And then you can start getting all those irregular cornea fun patients in your practice. But, there's a lot of different ways. I can recall starting my own private practice and building a specialty lens practice with another doctor. And, we used to go visit the cornea specialists in our area. We visited the LASIK centers because there's an awful lot of folks who are non-candidates who go to LASIK centers. We visited general ophthalmology and our optometry colleagues, and we just basically said, hey, if you've got these patients, and most people don't want to deal with them, to be frank. So it's like, I'd love to deal with them, just send them over and then you take good care of them and you co-manage them and you build a relationship not only with the patient, but the referring docs. And it takes some time. It took a couple of years to probably build, a specialty lens practice, but it happens. And with patience and with persistence and with fitting the patients that you already have, you can definitely do it. Absolutely. Anyone can.
Can you touch on co-management just a little bit and kind of tell me some of your the things that you've done to assure the other doctors that co-management is a great thing to do?
Sure. I mean, so we see an awful lot of co-managed patients in our practice now. And, the first thing, as I send them back for like a yearly visit, so they've been in their sclerals or their ortho-K lenses or whatever they're in, and I see them back and it's time to check up on their contact lenses and see how they're doing. And we'll go through and we'll evaluate their lens fit and prescription, et cetera. And usually about that time, I'll say, now, who does your regular eye care? Do you just come here or do you have a doctor who you see for your regular eye health checkups and glasses prescriptions on? Say, oh, no, I see Dr. So-and-so. Okay, great. Well, when was your last appointment? We just make sure that the patient's aware that we are not their primary eye care provider. We are their specialty eye care provider, and they still need that primary eye care provider. And so we find out when their last visit was and remind them you need to see them again, at the 1 year point or whatever you recommended, and just continue to foster that relationship. It's really the best case scenario. I feel like having two sets of eyes on someone's eyes is never a bad thing.
I agree.
I feel like co-managing is rewarding, and it builds relationships with your colleagues that are great, and you enjoy fostering those relationships. And honestly, if a patient comes in with scleral lenses and keratoconus, et cetera, if I don't have to spend time doing a dilation, hey, that's great. So less work for me. So again, the reality is, it's just, there's so many ways to do it. But I think taking the concept of just taking a minute and ask the patient, do we do your eye care, or does someone else? And I just want to make sure that you are properly cared for and you're getting your regular checkups, because a lot of times people come in, they just are scheduled for what we call a specialty lens follow-up. Then if I need to do their full exam because they're just a patient of our clinic, fine. But if not, then we're going to make sure that someone else is doing it and make sure they know that when they're scheduled to go back.
And then you keep in contact with those doctors on some of the specialty lens cases as well, correct?
Yeah, I mean, it's funny because I can recall being in referral practice 20 years ago, and yes, I am that old, but there was a time when we would dictate letters on all of our appointments for who was referred in, because I spent the first 10 years of practice in a referral practice for cataracts and other types of ocular surgery as well. But I think my feeling on that's kind of evolved to the point now where I feel like I'm just as happy with a copy of the patient's chart note as an actual letter from a doctor.
Yeah, I agree.
And so we just make a point of anybody who's tied to another doctor who it's flagged in our medical records system, then they just get a copy of our chart note every time we see their patient, and that lets them know that they're still involved and where things are at with their patient. So the communication generally is that. Now, do I have times when I still send a letter or call or get a call? Absolutely. And it never hurts, because when you get the phone call from someone you've referred out to, and that doctor takes the time to give you a phone call and tell you what happened with your patient, that's pretty cool. So we can't forget about those opportunities to make those impressions on people with a more personal touch. But I don't think you have to do that on every single patient, every encounter.
Well, I don't believe you've been doing this for 20 years. There's not enough gray in your hair for that.
It's the lighting. It helps.
It's the lighting. It's the lighting. Always makes us look better in the lighting. That's it. So as an educator, what tools do you suggest practitioners, both new and experienced, have practice to help them fit specialty lenses?
Well, there are the tools to grow your mind around the idea of how to fit these lenses, and then there's the tools you use to actually do the fitting. Right. And of course, as far as brain enhancing tools, I think that there are so many good resources now, webinars that are archived all over the place on all this stuff. And there's really no excuse anymore for someone to say, well, I just don't, there's just not enough information out there. There's so much out there, and so I think anybody who wants to put the effort in will find the resources out there to help you understand how to fit these lenses. Now, as far as the tools, I mean, clearly, I don't know how anybody practices without photography, but that's just me. I mean, that gives you so much of an idea of what you're doing with all your fits. And, not to digress too much, but I was just talking with Lyndon Jones earlier today, plug for my live stream CLS Live. Thank you. And we were talking about how still a good percentage of patients who drop out, it's fit related. Mm-hmm. Even you can make a lens out of the best possible material, but if the fit is bad, the patient won't be happy. And so, we use corneal topography on all of our patients, even just our basic soft lens patients, because if someone's going to drop out of contacts, I do not want it to be because of me. Right. I want it to be because either they have a problem with their eyes being too dry, or they don't want to pay for it, or whatever. But I don't want it to be because I put them in a bad fitting lens or the wrong material for compatibility. I don't want to be the reason for the dropout. So I'm doing everything in my power to prevent that. So corneal topography helps a ton. Beyond that, gosh, fluorescein and a slit lamp, obviously makes a difference to have those in your practice, and a Ratten filter.
Yes.
As far as other instruments, again, I mean, you can go so far with this if you want to. If you want to at the very highest level of specialty contact lenses, then it kind of also requires you to practice anterior segment disease management as well, because so many of these patients have concurrent disease, or the disease is why they need the lenses. And so are you going to manage that for the patient? Even if they see cornea or something else for their condition, do you want to be ignorant to what's going on with the patient's anterior segment, and you miss the opportunity to find a problem and get them back to their doctor? Or again, if you're just good enough at it, you can do it yourself.
Right.
So having, corneal tomography, having scleral topography, having OCT, having aberration measuring devices, et cetera, aberrometers. I mean, those things are all things that you grow into as a specialty lens fitter over time. I think starting off though, they're beautiful but you have to justify it. And again, so entry level corneal topography, then, maybe then you step up to a tomographer at some point, so you're better at disease management. And then maybe you step up to scleral imaging just to help become more efficient, because you're doing so many scleral fits, and then maybe you're doing so many scleral fits, but you want to provide better visual correction outcomes. You step up into aberrometry, but all those take a volume of patients to justify them, I think. And the reality is you can do wonderful things with sclerals. I mean, I have, if I go back in my mind 10 or 15 years ago, when I had nothing but a diagnostic set and a corneal topographer and a slit lamp, and you still made incredible results for patients. People were so happy with their outcomes and whatnot. So, from that perspective, you need all the toys to change people's lives with these lenses. You can do it without.
I think one of the most important things, if you're talking corneal topography too, is ortho K. You almost have to have corneal topography, because I know you do a lot of ortho K at the university. So I think that is really key for ortho K itself.
Yeah, again, if someone said, I really have a desire to do ortho K, but I just don't have a topographer, and I'm in a practice and I don't own it, and I can't get anybody to buy it for me, and you don't want to shell out on your own and buy it for yourself, I wouldn't say you can't do it. I mean, we know that, because our resident, Jonathan King, won the ABB challenge a year and a half ago, because he did a poster on ortho K using corneal astigmatism. And and so, the reality is if you have keratometry values and you know how much corneal astigmatism patient has, and you can refract, you can do ortho K.
Yeah, you can.
You can still figure out when you need a toric lens, and if you get good enough at retinoscopy, you can tell whether your treatment zone is centered or not, right? You can see that little with motion in the middle of the ring of against motion when you scope these folks. So it's possible, but it sure makes it a whole lot more fun to be able to show patients the results and stuff, and have your technicians help you with this rather than be fully doctor dependent on the process. So yeah, I mean, corneal topography would seem to be as much a necessity for ortho K as anything, and it probably is. But again, I wouldn't let someone be deterred from doing it if
I
they
agree.
don't have it.
Yeah, I agree. It's a very nice tool to have, especially for troubleshooting, and that's the way that we look at it. From a consultant perspective, it's really nice to have. We don't always get them either, but it's nice to have that, especially for troubleshooting.
Yeah, how can they troubleshoot with you if they can't show you anything? If they just scoped and said, well, I think it looks a little decentered this way, you're like, oh, what do I do with that, right? So having something to show consultation is obviously infinitely valuable if you want good help. So,
exactly.
Although I am always surprised at how you guys can take literal garbage from a practitioner and make a great lens out of the situation. I don't know how you do it, but
those are learned behaviors.
I guess
we've had to take a lot of garbage before.
Correct.
Learn from our mistakes.
You figured it out.
Yeah. So how do you believe strong focus on scleral lenses has impacted specialty GP fitting for students and neuro practitioners?
Yeah, I think that I think it's really opened the door for the next generation of specialty fitters to start to really develop, because you had those practitioners who really embraced GPs and were really good at it and still are really good at it. But many of those docs are getting up there, they're retiring or they're getting close to retiring. And a lot of them don't want to deal with learning the whole new process of scleros. So they just say, I don't want to deal with it. Well, along comes a new grad who doesn't have any past background in it, but they want to learn a skill, and they start by learning scleros.
Right.
And I definitely see, I do a lot of just online little training sessions for folks who want to do scleros. And most of them are, most of them have graduated within the last 10 years. And so I think that the demographic of the scleral lens fitter on average is probably, 15, 20 years younger than the average corneal GP expert. And that's probably good, because we need someone to come along and be that next generation. So I think it's opened up the door for new people to get involved. I think if we were still doing all corneal GPs, the newer practitioners wouldn't find specialty lenses were necessarily a place where there was a missing, gap in the practice where I can come in and fill that gap.
Right.
Because the senior practitioner would already be doing the corneal GPs, and well, I can't, they already are good at that, I'm not going to do that. But it's allowed the new practitioner to come in and say, well, nobody's doing this in your practice, well, I'd love to do it, so I'll step in. So it's created a whole new niche. I mean, I think, again, obviously Ortho K is booming as well, and that's another area that's just right, new practitioners step in, and again, they do absolutely go hand in hand. They're one and the same process. So again, I think the whole future of specialty GP fitting is going to have a different mentality. And so there's a great little story, Dede, about maybe 5 years ago already. I was sitting in our Grand Rounds conference with a dozen or so fourth-year students, right?
Right.
And we were talking about fitting corneal GPs for keratoconus.
Right.
And these students had already had their basic and advanced contact lens courses when they were in the didactic part of their time. And so they knew a bit about it, but it was a review session going through this stuff. And so as we were talking, one of the students raised their hand and said something to the effect of, so what you're telling me is if you've got apical bearing, you need to increase the sag of your lens. Like, well, actually, yeah, that's exactly what you need to do. But what was funny was they had already transitioned their thinking into sagittal height and depth-based rather than radius and width-based thinking.
Right.
And I can recall, again, maybe 10, 12 years ago, talk with one of the head consultants of a lab that will be nameless and saying, you guys have got to start embracing depth-based thinking and sag-based thinking for specialty lenses, because that's the way it's going. And they said, practitioners will never be able to make that transition. And maybe the senior practitioners who did a lot of corneal GPs can't, but when you've never learned it any other way, I think the new students, that it's far more intuitive for them to think elevation and depth and sag than it is to think curvature and things like that.
Well, and I have to agree with you, because we're seeing that as a consultant, seeing that with the newer practitioners that are coming out of school and starting, like you said, into practices with sclerals, we're seeing that a lot more. And I find that we do talk, even with corneal GPs, about elevation and landing and those terms that they're more comfortable with. And I have conversations with my team all the time about speaking the same language that the doctor is speaking and understanding that. And I think it is really important. I know that we've kind of adjusted some of our training that we do with our practitioners for that very reason. So we do see a lot more of that, especially talking to younger practitioners. So, it makes me kind of proud that we're not losing the corneal GP business, just because the things are changing. And I think that some of the newer practitioners that are coming out into the business do really have a capability of, when they learn scleral lenses, they can put more focus on GPs as well. I think they understand the concepts of SAG and some of the things that we talked about, years and years ago when we first started fitting. That was the way we fit.
Yep. Yeah, no, I agree. I think that as opposed to starting off with corneal GPs and migrating into other types of specialties, they're coming in more on the scleral and ortho-K and migrating back to corneal GPs. And I don't think that's a wrong approach. I think, again, there are little different ways of thinking about it. And so it's not necessarily that you should move from a simple to a more complex. They're really two different things. And so thinking about one, mastering it, then thinking about the other seems reasonable.
Yeah, there are a lot of similarities as well.
Yep.
So there's one question that I tend to ask every one of the practitioners that comes on with us, and it's, what would you say to a new optometrist that's just finishing school and they're really interested in getting into the real world of specialty lens fitting? Because there is a perception versus a real world. So what advice would you give to those new optometrists?
Yeah, so we touched on a little bit already at the beginning, that every practice is already potentially a specialty lens practice. There are, again, if you have a practice that has 3,000 patients, presumably 500 or more will be presbyopes, be wearing multifocal or more. Presumably a couple hundred of those at least will be young myopes who could be having their myopia managed through ortho-K or specialty soft or something. And so you have a specialty lens practice already. You just have to decide whether you want to develop it or not.
Exactly.
Whether you want to utilize that opportunity that you've been given. If you don't talk about it to the patients, they will never know about it. Again, just referring back to a conversation that I had with Lyndon Jones earlier. He said years ago when they started in practice, they decided to have 100 patients come in and not mention contact lenses to them. And then the next 100, they offered contact lenses to everyone. And he said the second 100, there were 6 times more people ended up with contacts. The first group, they only fitted them if they asked for it. The second group, they offered it to them, and they end fitting 6 times more lenses. So you have a specialty lens practice. You already have it. The question is whether you're going to offer it to your patients or not. Will you offer them specialty lenses or not? And then of course, once you grow that part of it and you become not just a novice at doing this stuff, but you become really good at it, then people will seek you out. It'll become the emphasis of your practice, and it will grow your practice. And again, specialty contact lenses can be very profitable if you take the time to learn how to do them well. And so in my private practice that I had before I came to the university, probably 1/3 of my patients were ortho-K patients, 1/3 were sclerals, and the other 1/3 were everything else. And I was used to say, would you rather see 25 routine exams a day, or would you rather fit 2 people in scleral lenses and 2 people in ortho-K? Because it's about the same bottom line. I could see 4 patients a day or 25. My quality of life is a lot better when I emphasize the specialty lens stuff that you can do. So if you're interested in specialty lenses and you've decided against residency, which isn't necessary, it's nice, but it's certainly not necessary. Just go to conferences like Vision by Design, like GSLS. Academy has some good contact lens stuff. I mean, they all do, but there's a few that are really good contact lens meetings where you can learn a lot about contacts, but you can also meet people that fit them, and you can glean from their expertise, and you can make connections where you can call on them later. That's one place. take advantage of these webinars that are all over the internet now, where you can learn the same way. And then contact the company. I mean, contact you, Dede, and say, hey, I kind of want to do the specialty lens stuff. I'm not really keen on how I get going with it, but help me out. And you would say, oh, I'll help you out.
I got that.
Here, read this. I'll send you this. When you're ready, let me know. We'll schedule to have someone come to your, or I'll do an online fitting with you, with the patient right in your chair. And maybe even I'll send someone to your practice if you get going with it enough and you want to do a handful of patients live in person. And the companies now just will walk you through the process of starting to being a fitter who knows what they're doing.
Yeah.
You're not going to be an expert after 6 fits, but you're going to be good enough that you can do it and you know how to do it. And so there's just no reason, if that's an interest to you, not to start with the meetings, take the online resources, but most of all, contact your lab and say, I want to do this and just need someone to hold my hand through the beginning stages. And you guys will.
Absolutely, we will. Not a problem at all. All right, now I want to switch gears a little bit because Jason, I've known you for quite some time and I know your brain is always working. It is always going, and sometimes it goes in different directions than the other.
To the extent that it actually works, it's working, right?
So one of our focuses on the show is art, and I know you and art and passion, I guess, are the two things that kind of go together. And I know that you have a passion for contact lenses, but you also have a little bit of an artistic talent. So tell me a little bit about some of the things we're going to feature for you today.
All right. So first of all, it's pretty sad that my whole life, work life revolves around contact lenses. And so my side things, both things I'll talk to you about, are contact lens related too. How boring is that? But, we talk about creativity and whatnot. And the reality is what I enjoy from a creative standpoint the most is contact lens design. And so, as you probably know, I've done some contact lens design work, and now that is ramping back up again now that I have started a new company with Charlie Creighton, and Charlie and I have our own company called Lens Design Solutions, plug for Lens Design Solutions. And our company is just about creating new designs for labs that want to have something new in their portfolio. So that's a creative thing, to sit and come up with new ideas, better ways to create a multifocal optic, or better ways to get an ortho-K lens to manage myopia, et cetera, et cetera. So that's part of it. When you say your what do you do in your side time that's creative, I'd say create contact lenses, which is pretty sad. But the other part of it is, as we already talked about a little bit, is I have fun with video editing and picture editing and things like that. So kind of my latest interest is creating interesting art using photography of specialty contact lenses. So taking really nice pictures of maybe an ortho-K fluorescein pattern, or a scleral lens fluorescein pattern, or just a corneal GP with a great fluorescein pattern. And that fluorescein is so bright and vibrant. Then you go into a video edit or a photo editing software and you start changing the colors, and you can create some really cool effects by making that fluorescein red or orange or purple or something else. So I'm having a little bit of fun. I have to find the spare time most of the time to figure out when I'm going to sit and play with these pictures to create them. But it does create some pretty cool artwork, and I think it looks good on the wall of an office that does specialty contact lenses, to feature photographs of eyes with lenses on, but jazz up the color a little bit to make them more eye-catching and interesting.
So do you plan to be the next Andy Warhol of contact lens imaging?
My hair is probably not gray enough. So maybe as I get older, perhaps I could get into some cool glasses too, though. Maybe.
Yeah.
Am I quirky enough, Dede? Am I quirky
You're
enough?
definitely
Andy
quirky
Warhol?
enough.
I don't know. Okay. There you go. then the stage is set for the
But i.e.
future.
it takes one to know one too. So
I suppose so. Yeah. You've got a little more Andy Warhol going than I do so
I do,
far.
absolutely.
So yes, I have to learn from you a little bit.
All right, Jason, thank you so much for being with us today. I've really enjoyed talking to you as I always do. So thank you.
Are we done already?
We're done already. So thanks again
bummer.
for being with us, and
Always
really enjoyed having you here.
Thank you so much. Anytime.
Thanks. And I'd also like to thank our sponsors today, ABB Optical Group, for all of their support for Dede Talks, the Art of Specialty Lenses.